Hello everyone, good evening. Today we'll discuss about treatment of neonatal seizures. This is updated guidelines. This updated guidelines is from an ILAE task force. This has been released in our IAP August journal. Okay. So, neonatal seizures. The most common neurological emergency during the first month of life is neonatal seizures. So, this is the most common neurological emergency in the first month of life. Is neonatal seizure. So this year this ILAE has emphasized the importance of video EEG. So the recent ILAE classification of these neonatal seizures emphasizes the importance of the video EEG. Okay, since this children with hypoxic ischemic encephalopathy have only pure electrographic seizures in 50 to 80% of cases, so they have emphasized the importance on video EEG and amplified EEG. This amplified EEG is nothing but a simplified bedside neurological tool that displays one or two channels of EEG in a filtered and a compressed manner. Okay. So we will see the difference between the ILAE drafted in 2022 and the WHO ILAE guidelines. That was the previous guidelines. Okay. So first question. So this is 2011 guidelines and this is 2023 guidelines. Okay. First question is, which newborn seizure require anti-seizure medication? So which newborn seizure require anti-seizure? This ASM is nothing but anti-seizure medication. So according to 2011, it is clinically apparent seizure that should be treated if they last for more than 3 minutes or a brief serial seizures. So only a clinically apparent seizures that last for 3 minutes, more than 3 minutes are being treated in 2011 guidelines. According to 2023 guidelines, it is all the electrical seizures. Electrical seizure is all the seizures that come record in EEG is also being treated with or without clinical correlation. So all the electrical seizure with or without clinical correlates needs to be treated. Okay. Should we treat electrographic seizures? Next question. So should we treat electrographic seizures? Here it is, you have to treat all the seizures according to our new guidelines. Old guidelines was all the electrical seizures, that is EEG proven, even if not clinically apparent, should also be treated. That was, this should be treated also. Okay, this both are same. Next, our third question was, which is the preferred first line anti-seizure medication for a newborn with seizure? So preferred first line anti-seizure medication for a neonatal seizure. So according to old guideline, that is phenobarbital is the first choice to control the neonatal seizures. So according to new guidelines also, it is phenobarbital is the first line. But the changes here are, if the seizures are due to channelopathy, if the seizures are due to channelopathies. So channelopathies, if by a genetic testing, you have done a genetic testing and there is a strong family history, if there is a strong family history and genetic testing is positive, then you have to treat this newborn with a sodium channel blocker. So sodium channel blocker will be the first line of treatment for the children with channelopathies. So sodium channel blockers are nothing but these are phenytoin or carbamazepine. Okay, so this is the preferred first line of ASM for neonatal seizures. Next, fourth question is, if a newborn has seizures and it is controlled on the current ASM, when should the medication be discontinued? Okay, so this is 2011 and this is 2023. So when should the medication be discontinued if the newborn seizure is controlled? So if the seizure control is achieved, stop the ASM when the neurological examination is normal. So according to our old guidelines, so when the neurological examination is normal and or when there is a normal EEG, if the child is seizure free for more than 72 hours, then you stop this anti-seizure medication. Okay, but in our new guidelines, following a cessation of acute symptomatic seizures, so when there is an acute symptomatic seizures has been stopped both in the electroclinical or electrographic without any evidence of neonatal onset of epilepsy, you can discontinue this ASM. So ASM should be discontinued before discharge if there is a cessation of the acute symptomatic seizure. Whether it is an electroclinical or electrographic. Okay, regardless of their MRI finding. This is according to the new guidelines that you should stop the ASM before discharge. Okay, if there is a cessation of an acute symptomatic seizure episode. Okay, the next question is, which is the preferred second line ASM for newborns with seizure? So preferred second line drug or second line ASM for the neonatal seizure. So in according to our old guideline, it was either benzodiazepine, phenytoin or lidocaine. This phenytoin and lidocaine requires cardiac monitoring. Here according to our new guidelines, it is phenytoin, either one of the following. So it is either phenytoin, levetiracetam, lidocaine or midazolam. Any of this can be used as a second line drug for a neonate with a seizure. This in neonate with a cardiac disorder, levetiracetam is preferred. So this levetiracetam is preferred in a child with a neonate with cardiac disorder. Okay, this is the fifth recommended guideline. Next, if a newborn has a seizure and is controlled on current ASM, how should the medication be discontinued? So that first was like when should the medication be discontinued. Now it is how the medication should be discontinued. So in a previous guideline, if the seizure is controlled with a single ASM, that can be discontinued abruptly without tapering. But if required more than one anti-seizure medication, then it may be stopped one by one, with the phenobarbital is the last drug to be withdrawn. So according to our old guideline, if on one medication or a single medication, this can be stopped abruptly. Okay, supposing if the child require more than one anti-seizure medication, then you have to stop one by one, with phenobarbital will be last to discontinue. Okay, this was the previous guideline. Present is there is no change in this current guidelines, no changes. So this will be following. Okay. Next, what is the role of pyridoxine or pyridoxal 5-phosphate in a neonatal seizure? This will be 7th. Role of pyridoxine or pyridoxal 5-phosphate in neonatal seizure. So in the previous guideline, if there is an absence of hypoglycemia, meningitis, hypocalcemia, or any other obvious underlying etiology such as HIE, intracranial hemorrhage, or infarction, this pyridoxine treatment may be considered. Okay, so in absence of all this, you can consider pyridoxine. So present, a trial of pyridoxine should be an add-on. To anti-seizure medication, can be attempted in a neonate. So you can give in a neonate if it presents with the clinical features of myoclonic jerks. If the child have a myoclonic jerk, spasm, or abnormal eye movements, or if the child is grimacing. These are the clinical features. If any one of these clinical features is there, you can add on this pyridoxine. Or if the EEG finding shows, okay, if the EEG finding shows a burst suppression pattern or any discontinuity, these can be suggestive of vitamin B6, that is pyridoxine dependent epilepsy, or in seizures unresponsive to a second line anti-seizure medication without any identified etiology. You can start on a trial of pyridoxine in this child. Okay, this is about the role of pyridoxine. So what is the value of EEG in the management of seizure? Next, so according to our new guidelines, it is the stronger role of EEG in confirming and diagnosing neonatal seizure. So it is a must to detect and treat the electrical seizure in addition to clinical seizures. Okay, so our 8th question is role of EEG. So this is must. If EEG is also positive, suggestive of seizures, you have to treat, even though you don't find any pure clinical seizures. But in our older guidelines works, so contains specific recommendation based on availability of EEG, where available all the clinical seizures should be confirmed by. So here it is in the previous guidelines, it is based on availability. So wherever a clinical seizure, you find a clinical seizure, you have to confirm it by EEG. So this is the difference between 2023 and 2011. Okay. So next question is whether this therapeutic hypothermia reduces seizure burden. So does therapeutic hypothermia reduce seizure burden. So in 2011, the therapeutic hypothermia was not in clinical use in most of the centers, so the text was not available. While here in 2023, weak evidence, there's only weak evidence suggests that TH is useful to reduce the seizure burden in a child associated with the perinatal asphyxia and HIE. So there is only a weak evidence. Suggests that therapeutic hypothermia reduces seizure burden associated with perinatal asphyxia and HIE. Okay, so these are the new 9 recommendations of 2023 ILAE. So first one, just in a short, I'll tell you. So which newborn seizure require anti-seizure medication? So according to one new, it is all the electrical seizure with or without clinical correlates require anti-seizure medication. So should we treat seizure with EEG or electrographic seizure? Yes, you should definitely treat that. What is the preferred first line? It is always phenobarbital, but if the child has seizure due to channelopathies by a strong family history and a genetic testing to be positive, then you use a sodium channel blocker is being used, such as phenytoin and carbamazepine. Fourth is, when should the medication be discontinued? Our new guideline says it is before the discharge. You have to stop the medication if the seizure is due to an acute symptomatic seizure, regardless of their MRI finding. What is the preferred second line? So any 4 can be used. Either phenytoin, levetiracetam, lidocaine or midazolam can be used. Among this, levetiracetam is used when the newborn is having a cardiac disorder. Sixth is how the medication should be discontinued. If the child is on a single medication, you can stop it abruptly. Suppose if the child is taking more than one medication, then you have to stop one by one, and phenobarbital will be the last to be withdrawn. What is the role of pyridoxine? Next question. It is given as an add-on to the anti-seizure medication. If the child has clinical features such as myoclonic jerks, spasm, abnormal eye movements, grimacing, or if the EEG shows a burst suppression pattern and discontinuity pattern, then you can start on with pyridoxine. What is the role of EEG? New guideline says it is a must. EEG is must in every child. Then you have to start. If the EEG shows a seizure pattern, even if there is no clinical evidence, you have to treat. Next, the 9th is, does therapeutic hypothermia reduce the seizure burden? But it is a weak evidence. There is a weak evidence suggests that it can reduce the seizure burden in a newborn associated with the perinatal asphyxia and HIE. Okay, thank you. This is a short video on this updated guidelines. Thank you. For more videos, kindly like, share and subscribe my YouTube channel. If you want any topic specific, kindly